All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So this is a different camera. I went back to Nikon D800, which is a 10 years old camera. I think it is performing better than Sony Alpha 7C that I had. So anyways, that is one. It still needs adjustment. It seems like a little overexposed. Secondly, I want to show you these are, can you imagine? This is actually clay. So my wife brought this back from her pottery studio, and she actually drew these on this clay. This is so artistic. Check this out. So I loved it. I thought I'll show it to you. With this piece, this is also handmade. I cannot imagine. And she paints them by her hand as well. So very artistic. And finally, I requested her to give them to me so I can show them to you. And finally, look at this. And can you see that this stroke, the paint stroke, is she actually strokes it or paints it? And her pottery has become quite popular for these artistic paint strokes. Okay, so with this, let's start our discussion. The discussion is about the study. It came out in January. It is by Mass General Hospital, researchers from Mass General Hospital, Brigham and Women Hospital, Boston Children's Hospital, Harvard Medical School, and so on. The study, the basic summary of the study is that they saw that in children and adolescents who had myocarditis, these children had full-length spike protein circulating in their blood. And I know that many of you would say, well, we knew this already. That is correct. However, this is my second study that I'm presenting with the full-length spike protein present in the blood circulation without antibodies attacking them. That is the interesting part, that somehow these vaccine generated spike proteins behaved very similar to the spike proteins in MIS-C disease of children from COVID and were circulating in the blood circulation without antibodies. That is interesting, without antibodies, which also means that pathogenesis of the myocarditis becomes a little more clear. And I don't want to brag about it, but those pathogenesis that I have been discussing, some of them actually apply and are proved by this study. So let's look at this study together. Very important study. So this is drbeen.com. In the description of this video, there is a link that gives you access to drbeen.com's final days of inexpensive lifetime access. Our courses have actually now, if you see, where we have reached is that all the thumbnails are now ready. So before this, performance was the issue, then the thumbnails. So now the thumbnails are done. This chest X-ray course has become published. Now the second course that will be published is cardiovascular system. It has 117 lectures in it with 52 hours of videos, and it will be about $500 to $700. Interestingly, the link in this description gives you almost free access to all of these. But anyways, our members site, this courses site is almost up. This is the study, American Heart Association, circulating spike proteins detected in post-COVID-19 mRNA vaccine myocarditis. This is the free one. If you go to American Heart Association and try to request access, this is $35 or $40. However, if you just search for this title, then you'll find this free access as well. I have linked to both of them in the description. In addition to that, I have some more. There is an editorial page about this study discussing the possible mechanisms of pathogenesis of myocarditis because of spike protein, and I would discuss that as well. And finally, an important thing, and that is the cardiac pericytes. So we have been discussing brain's pericytes, or the cells that are surrounding the blood vessels to kind of protect them. In the heart, we also have pericytes that surround our blood vessels in the heart. And when they get damaged, the heart can become inflamed and damaged. And one of the pathogenesis is the pericyte damage by the spike protein, full length spike protein. So let's start. Let's start with, so one more picture and then we stop. This is Luffy. So nowadays, Luffy likes to go out. So remember when you say, where is Luffy? So he is sitting outside under this little table, and he sleeps there all the night and day. Well, not the night, but most of the day. And here he is sitting. So with this, now time for my drawings. So these are gifts for humanity, and they are continuing. This is the study. I just showed it to you. This is a small study in number of patients. However, it is significant in terms of the observations that they had from the blood samples they collected. 16 patients of myocarditis between the age up to the age of 18 or 19, and 45 vaccinated control. So everyone who participated in the study were all vaccinated. There were 16 patients who got vaccinated by mRNA vaccine, and then they developed myocarditis and presented to the Children's Hospital. And then there were 45 also adolescents, and they were also vaccinated, but they did not have myocarditis. So researchers compared the blood samples and the immune systems and antibody profiles and spike protein profiles of these two groups, which I think is amazing. So I want to give you the summary point right away, and that is full length, free. This is important, free spike in the blood of children with myocarditis. And you could say, what do you mean by free? What I mean by free is that the spike protein is there. So let's say this is a spike protein. It is there without any attacking antibodies to it. And then you could probably ask this question that, how do you know that there are no antibodies attached to it? So what they did was they took the spike proteins from the blood sample, and then they suspected that maybe there are antibodies attached to them. And so they denatured with chemicals that would only denature the spike protein. So they had chemicals added to the samples, which would only attack the spike proteins and denature them. And what will then be left will be the spike protein itself and then denatured antibodies. And they found no denatured antibodies, which meant these were free, full length spike proteins present in the blood samples. Now, of course, then the next question that would be in your mind will be, how did they end up here? Number one, do they end up in everybody's case? And as you saw, that 45 other vaccinated individuals, same age, did not have them. And these were a smaller number that had them. So then the next question will be, what happened in these? And these are the discussions that we'll do. Now, no free spike was found in asymptomatic vaccinated control subjects. And I want to also quickly read a part of their discussion, which is important, and that is this one. They said, what is new? Adolescents and young adults who developed myocarditis after severe respiratory syndrome, coronavirus disease, mRNA vaccination, display persistently elevated circulating levels of full-length spike protein unbound by antibodies. And if you said, what is the level of persistence? 3 weeks, up to 3 weeks. They did not check afterwards. Then this second paragraph is really important to note. No evidence of autoantibody production. So autoimmunity, remember I used to become worried about the autoimmune reactions. I believe that there still are patients in whom autoimmune disease occurs. However, in these patients that participated in this study, the autoimmunity was not observed, which is a better thing because you don't want a child to receive vaccine and then for the rest of their life have an autoimmune attack on their cardiovascular system. So no evidence of autoantibody production, concomitant viral infection, or excessive antibody response to the anti-SARS-CoV-2 mRNA vaccine was identified. So they didn't find any concomitant infection as well, because the question could be, is it the SARS-CoV-2 infection that is causing this problem? So they cleared it out that they tested for SARS-CoV-2 antigens and they did not find them. So it was vaccine. One, they also wanted to make sure that was it an aggressive response by our acquired immune system? Because that was also a pathogenesis, that was also a thought that our acquired arm, that is cytotoxic T cells, they respond so aggressively to the vaccine that they go and attack the cardiac system as well and cause inflammation of the heart. The researchers did not find that. So then that means right in the beginning of this talk, in your mind should be the question, okay, if it is not autoimmunity, or if it is not antibodies, if it is not T cells, then who is causing the damage and what is causing the inflammation? I'll give you the short answer. Damage is caused by the spike protein, and the inflammation is caused by the innate arm of the immune system instead of the acquired arm. This is the summary. Now I'm going to go and present the whole paper with my points. So the pathogenic factors. This is a rather complex diagram of the immune system and the cells that are being presented or created. However, what is interesting to note here in this diagram is the following. They saw in the patients who had myocarditis that platelet levels were lesser than those who were in control group. That is very interesting because we have been thinking that it may be coagulation that is increased and clotting is occurring, which is causing the microvascular system to not operate correctly and have issues. Now, it is possible that platelet levels are low because these platelets have become consumed in clot formation. But anyways, they found platelet levels to be lesser in patients with myocarditis. Second thing that they found was that leukocytes or white blood cells in general were slightly increased, although statistically significantly increased compared to the control group, and in that group, especially the neutrophils were more. So that is another finding they have. Then they found out that the innate arm, the dendritic cells and the macrophages and other innate arm cells, their cytokines or their chemical mediators that they release, or chemokines that they release and cytokines that they release, these were more in amount in the vaccine and then myocarditis patients compared to vaccine and no myocarditis patients. So it kind of shows that innate arm was overreactive. That also removes this theory of some doctors in the past saying that the vaccines would damage the innate arm and destroy them. Here we are seeing that it is actually vaccine triggering the innate arm and causing innate arm to create inflammation compared to acquired arm to attack the system, the tissues. Then on the acquired arm side, the T cells and the B cells, they saw no difference in antibody production or antibody levels. And they also saw no difference in the cytotoxic T cell or helper T cell level. So that means acquired arm did not have much to do with the myocarditis. This also means that the autoimmunity, remember the memory is primarily in the acquired arm. Memory B cells, memory T cells are part of the acquired arm. So if the acquired arm isn't overreaching its need, if it is not more aggressive, it is not becoming more prominent or dominant in its effect, then it's not the one that is causing the problem. So that is actually a very important observation. So the other thing that was interesting for me was, as a doctor, was that the cytokine profile, that is the chemicals released by various inflammatory cells, that cytokine profile was very similar to the profile of MISC, which is the after SARS-CoV-2 infection in young children, multiple inflammatory system disorder for the multiple organs. Vaccine caused in young adults and children a very similar cytokine profile. So that's very interesting. A very similar profile to this, to the infection itself. Total leukocytes were more, especially neutrophil. Platelets were less. Adaptive arm was normal. T cell were normal, meaning compared to control, they were the same. What kind of interleukins were different? So if you see here, interleukin 8, interleukin 6, tumor necrosis factor alpha, interleukin 10, interferon gamma, interleukin 1 beta, interleukin 4 was less. So we know that interleukin 8 and 6 and the they come from innate arm. We know interleukin 10 comes from the helper cells. It can come from other cells as well. We know that interferon gamma comes from the T helper 1 side cells. So there are interleukins that are from acquired and adaptive. However, innate arm, did I say acquired and adaptive? They're the same. Innate and acquired arm. However, innate arm interleukins were more. So if you read here, these results suggest that post-vaccine myocarditis is associated with normal adaptive, and T-cell immunity, but modest innate activation. That is very important. Then this is an important part, and that is they're talking about the S1. Because there is also a theory, there was also a possibility that it is the S1 part. It is the spike protein that has become cleaved, that has become broken into S1 and S2 part, and it is the S1 part that is running around causing the damage. Even S1 part picked up by the monocytes, and that is causing the damage, Dr. Bruce Patterson's work. Here they said that the S1 was present in myocarditis patients and in vaccinated without myocarditis or control patients. However, the frequency and the concentration of S1 was equal in both, or similar, they said, in both. Secondly, the S1 that was detected and isolated had antibodies attached with it. That means our body or these patients' bodies were responding correctly to the S1 and were directing the immune system to attack the S1. So, similarity between the patient and the control of S1 frequency, that is how many patients had it. The control, I believe, had 34% and the vaccine had 29%, or the other way around. Let's see. After incubation, radiation was detected in plasma of 34% of vaccinated and 29% of the myocarditis. So 34% vaccinated and then 29% of myocarditis, I said it correctly before, they had the S1. Secondly, the concentrations were similar. Thirdly, antibodies were attacking them. So which rules out the role of S1 in myocarditis? Every single concept today is very important for us to understand what is causing myocarditis and how to manage that, even how to think about preventing it, and finally, what is a prognosis, meaning in the long run, what may be the outcome. So it's not S1, which is actually a good news. It's a small study at the end of the day. It could be that, hey, it is so small, 16 and 45, that we can just not use these results. That is fine. However, it is a very important leading or pilot study you can use that as. Then the full length spike. So if you see here, it is in notable contrast. Adolescents who developed myocarditis had markedly higher levels of free full length. I wish that every time there is the word free, there is something like a loudspeaker that says free. Can I say free with the megaphone? Free. So, anyways, free, meaning no antibodies attacking it, which means these spike proteins are escaping cleavage, that is breakdown, and destruction by the acquired arm. That is what free means. So, high level of free and full length spike protein in their plasma, 33.9 plus minus 22.4 picogram per milliliter, unbound by antibodies. Whereas asymptomatic vaccinated control, those who were vaccinated, who were controlled, who were not symptomatic for myocarditis, had no detectable free spike protein. If I kind of paint with a broad brush here, everything else was similar in the two groups. It's the free, full length spike protein that was the main difference, and the innate arms activation was the main difference. So then that would direct you to say, all right, I need to go figure out how does full length spike protein cause the damage. And I'll explain that. I have done these talks many times before, how full length spike protein causes it. I'll discuss in brevity again today. Then this is very interesting, this statement. Although post-vaccine myocarditis clinically means there are symptoms, occurs more commonly in males, elevated spike was seen equally in both affected males and females and males. That is also very interesting. That means girls, young girls, they also were developing similar concentrations of free spike protein, but their chances of developing myocarditis were lesser than boys. That's very, very interesting. So it is not that girls somehow didn't have the full length spike protein, or their body was behaving something in a different way, or there were some hormones involved. They had the same levels of free full length spike protein, but still not had the same percentages of myocarditis incidence. We found a minimal increase in spike levels after dithiothrietol, so that is the one that would denature the antibodies, suggesting that most of the antigen is freely circulating and unbound by the antibodies. So, okay, we saw that. Antibody bound spike was detected in only 6% of the vaccinated control subject. Then, this is also important, both free and antibody bound spike, which was detectable only in patients who developed vaccine-induced myocarditis. So look, the words vaccine-induced myocarditis remained detectable up to 3 weeks after vaccination. I think that this would have been a little longer as well, but anyways, for them, it was detectable up to 3 weeks. I have done another study where the production of spike protein from messenger RNA in the local lymph nodes continued even up to 6 months. So what are the learnings? John Snyder says, free, free, free at the Spike Imperium. Free, yes, free. If you take away one thing from today's talk, it is free. Okay, but Dr. Bean is still just low price of almost free for some time. Okay, learnings. Autoimmune component not observed in this study. Now, there is an important part. Remember anti-idiotypical antibodies or network theory by Neil Jenkin? I have discussed that many times. In this study, there actually isn't anything that alludes to an antibody that may be of that type. So my conclusion from this study is that they did not see autoantibody responses. However, it is strange for me to observe, this is the editorial if you see here, this editorial, the article is commented on by the following shedding. And so here is the comment editorial by Beckham Boskert, MD, PhD. Good. Now check the editorial. What do they say? In this editorial, they are trying to present what could be the possible pathologies just because of spike protein present and immune system not really reacting through the acquired arm. Here is what they said. They said these results of the study raise the question of why circulating spike protein levels remained elevated despite adequate levels and functionality of anti-spike antibodies. Hypothetical explanations include prolonged existence of mRNA that evades destruction. We have done this discussion that in some cases, vaccine provided mRNA can live in the local lymph nodes for up to 6 months and continue to produce antibodies. So this point is valid. Increased dose delivery of mRNA, that is also very, very important. Many folks here under the YouTube videos have commented that do we think that it is the dose that should be different for children? And many studies have actually alluded to the fact that, hey, the dose for children should be lesser. So here they're saying maybe it is the amount of mRNA given to children, which is the same. And this, I agree with this. And this tells me that if you think about CDCs and FDAs of the world, their job, if they were not closing their eyes to the vaccine related effects, side effects, and they were leaning in and they were saying there is damage occurring and let's see what that damage is, they could have gone back to the pharmas and said, run a trial to prove or disprove following thinking, following line of thought. In this 3 years or at least 2 years of vaccination, they could have done so many studies. They had $1 billion for doing long COVID studies and they haven't proven anything or provided anything. But if they were just not keeping their heads in the sand, they could have actually ruled out or ruled in these things. They could have gone back to vaccine companies and said, reduce the dose and then let's see. Although there were dose differences in the trials, but here in the production, you are seeing that there may be a dose related issue. Then the third one, the possible role of anti-idiotype, which I have been hammering for some time. Anti-idiotype antibodies resulting in the attenuation of neutralizing spike antibodies. So we have done this discussion in the past that anti-idiotype, I'm going to wave my hands and explain this. So give me 1 second. I'm going to go back here. So we know that if this is a spike protein and this is the neutralizing antibody, then our body makes another antibody against this antibody. This is called anti-idiotype antibody. But when this binds with it, this new antibody looks like a spike protein and it can behave like a spike protein. One, secondly, it can complex with this neutralizing antibody and they both can become useless because spike is running around free and these two guys are complexed. However, for me, what is strange, and maybe that is just my lack of understanding of this all, is that researchers said it clearly that we do not see antibodies that are present excessively in one or the other cohort. So then the possibility of anti-idiotypical antibodies being present and being complexed does not look plausible. But I'll just add this, that it is possible that anti-idiotypical antibodies came in, they worked with the neutralizing antibody, they complexed with them, and they just took them away. They swept them away. They vacuumed them away. And what is left was the culprit, this full-length spike protein dancing around in the blood because the other antibody, neutralizing antibody, has been washed away by the anti-idiotypical antibodies. If anti-idiotypical antibodies are present, then we'll have one more issue, And that is that these anti-idiotypical antibodies will bind with ACE2, because these anti-idiotypical antibodies have a binding site that is very similar to the RBD, especially the receptor binding motif of the ACE of the spike protein. I've discussed it many times. And that means anti-idiotypical antibody will bind with ACE2, that will cause ACE2 downregulation, that will cause nitric oxide production disruption, and that will cause inflammation of the endocarditis and endothelium, myocarditis, endocarditis, and endothelium. I have been saying it for a long time. But there were also folks who had been saying, well, the vaccine is in the veins and that is why it is causing heart issues. So we were just looking in the wrong directions for a long time. Here are the some of the possibilities. There are actually more. So back here, is there an autoimmune component? At least they did not see it. However, can I further qualify it? If we have anti-idiotypical antibody and we have the antibody, simple antibody against spike protein, then these can become an autoimmune issue if the anti-idiotypical antibody B cell becomes a memory cell, goes in the bone marrow, lives there, and then continues to produce this ACE2 binding antibody forever, then the patient would continue to get endothelial problems and ACE2 related inflammatory issues, ACE2 downregulating inflammatory issues forever. Innate arm is more active in this study, was observed to be more active than acquired arm, which means that those theories that somehow vaccine would destroy the innate arm are incorrect. That doesn't mean vaccine doesn't cause damage. We are looking at the damage, we are studying the damage, but the mechanism that some folks propagated for years is wrong, at least in the context of this study. Then acquired arm, no difference in control of B cells and T cells. Aggressive T cells were not observed. Autoantibodies were not observed. Molecular mimicry was not observed. These are all I'm pulling from the manuscript. These are not my thoughts. And this is why I put a question mark here that anti-idiotypical antibody is wrong. But if you see here in their editorial, they say that is a possible mechanism. I think that too. Then female versus male, I just answered that female versus male, they have a similar concentration of the full length spike protein, but females are responding less with myocarditis versus males. Was this an inadequate neutralization capacity? So they said that what they did was they took blood samples, of course, from the myocarditis patients, children, and from the vaccinated but not myocarditis children. And they saw the neutralizing capacity of the antibodies present in their blood against the spike protein, and they found them to be equal. So it was not the neutralizing capacity. So the children with myocarditis were not producing non-neutralizing antibodies. They were producing correct antibodies. But somehow the spike protein was evading these antibodies, either through the anti-idiotypical antibodies or other mechanism that I just mentioned. So then the question becomes, and I think this is the most important answers that we'll get today. And if you've already watched or seen this study with others, then sorry for repeating it. What is the pathogenesis of myocarditis? At least in the light of this study, the pathogenesis of myocarditis becomes spike-caused issues, not autoimmune system, not aggressive T cells, not hormonal differences, not genetic problems, but spike-caused issues. Or as they said here, vaccine-induced myocarditis. I would insert vaccine-induced full-length spike protein causing myocarditis. So how did that happen? Here are some things to note. So here is the mRNA, arrives, gets into the muscle cells, Inside the muscle cell, mRNA works to make spike proteins. Those spike proteins now have to escape. Either the cell got destroyed and the full length spike proteins came out, or the full length spike proteins leaked out of the cell through exocytosis, or some other mechanism. Important thing is they have to be full length. They cannot be cleaved, they cannot be destroyed. If they are destroyed and cleaved, then they are not of any use, at least for this pathogenesis. So there can be destruction inside the cell, there can be cleavage outside the cell. Remember, S1 and S2 are cleaved from each other. So S1 pieces that are cleaved away are of no use, which is good. It is those spike proteins, full length, that escaped. Then what did these do? So here is a blood vessel. Imagine that this is a heart's blood vessel. All blood vessels, bigger blood vessels, have three main layers in their walls. Imagine they are made up they are made up of three pipes sitting in each other. So the most internal pipe is endothelium, or the inner surface of the blood vessel. So here in my diagram, this is the endothelium. Endothelium is in contact with the blood. It's the inner surface of the pipe, the blood vessel. Endothelium has ACE2 receptors on it. Endothelium is also gotten integrins on them. Integrins are molecules on cells with which they bind to other things. They integrate with other things, integrins. So there are integrins on endothelium and there are ACE2 on endothelium. Then outside the endothelium is a middle layer, which is usually the target of atherosclerosis. This layer has some smooth muscles and stuff. So this is called tunica media. The most internal layer is called tunica intima. Then there is an outer layer called tunica adventitia. Outside the tunica adventitia, the outer surface of the blood vessel, there are cells that are sticking to it. These cells are called pericytes. Peri means surrounding, pericyte, cell that is surrounding. They are surrounding the blood vessels in the heart, and they are protecting the blood vessels. They're controlling the permeability of the blood vessel. They're controlling the function of the blood vessel. And guess what full length spike protein does? I have done this in detail many times. What it does is full length spike protein can connect with ACE2. I would add over here, this is not from the study, I would add that anti-idiotypical antibody can also connect with ACE2. We have done those studies separately. ACE2 becomes downregulated. Now, ACE2's behavior is anti-inflammatory behavior. ACE1's behavior is pro-inflammatory behavior. They normally stay in a balance. But when you downregulate ACE2, when you use ACE2 for useless thing, and that is binding a spike protein to it, instead of binding angiotensin 2 to it, then ACE2 doesn't function correctly. It's not available in the correct numbers. It is downregulated. And the result of that is, number one, ACE2 is not present for the normal substrate to attach. Number two, nitric oxide production inside the cell becomes disrupted. Number three, superoxide dismutase production becomes disrupted. Number four, platelet activation systems become disrupted and they start getting released. I have done this discussion. So the end result is the endothelium, this cell, will become pro-inflammatory, will develop more reactive oxygen species, will not be able to handle itself against the inflammation. And because of all those reactive oxygen species that are present from this cell coming out in the environment, will cause other immune system, innate immune system cells, that is dendritic cells and the macrophages and neutrophils, to attack these cells, and local inflammation would occur. At the same time, when nitric oxide is less, then the blood vessel cannot dilate, because nitric oxide's function, one of the functions, is to work on the smooth muscles under the blood vessel wall to relax them. So now we have a constricted blood vessel that is not allowing free flow of the blood, which causes the trash or the lactic acids and other such metabolites to accumulate, which causes less flow, also causes less nutrition to become available, less oxygen to become available. and that would cause issues with the local tissue. So endothelium is damaged and inflammation occurs. Pericytes are damaged by the spike protein, and that also causes inflammation. So outside of the blood vessel, outer wall is inflamed, inner wall is inflamed, and if it is heart, then the inner wall is endothelium, and just in the middle is the muscle. They all get inflamed. And here we have spike protein or anti-indiotypical antibody, they both causing damage to the blood vessel in the heart. Now, in this process, if you said, how will clotting occur? We did this thing that when the spike protein binds with the endothelial ACE2, then the superoxide dismutase is reduced. Superoxide dismutase's function is to reduce the reactive oxygen species. It is superoxide dismutase. Superoxide is a reactive oxygen species. Dismutases it. It changes its behavior. So when the superoxide dismutase enzyme isn't working correctly, then the reactive oxygen species will be produced in the endothelium, cause local damage and inflammation, plus the reactive oxygen species, when they're released from the endothelium into the blood circulation, they cause platelet aggregations and clotting. So we got pericyte dysfunction, we got ACE2 downregulation and inflammation, we got reduced nitric oxide availability, we got endothelial issues and hyperpermeability of the endothelium. Blood vessels become leaky, congestion occurs, inflammation occurs, mediated by integrins. So here, this is a spike protein bound to an ACE2. This is a spike protein or multiple spike proteins entangled with integrins. End result is this endothelium is in trouble, heart's internal wall is in trouble, myocardium is in trouble, external wall of the blood vessels are in trouble. When heart's own blood vessels are in trouble, then the muscle will become in trouble as well, because the lactic acid and the nutritional supply, lactic acid wash away will not occur correctly, nutritional supply would not occur correctly, and the muscle will become inflamed. Then they say, thus the spike antigen itself, which evades antibody recognition rather than invoking immune hyperreaction, may contribute to myocarditis. It is the spike protein that escaped or evaded the immune system and then went and did a number on the heart, instead of spike protein causing the immune system to go nuts and then the immune system causing the damage. Then they say, our data suggests that there is a potential unique mechanism of myocardial injury after SARS-CoV-2 mRNA vaccination associated with a robust innate immune response. So then, is it vaccine in the veins causing the cardiac problems? At least in the context of this study, no. Then who is at risk? Which child would develop this? Still not known. And I'll give you an idea of the vaccine's dose in a second. But other than that, not known. So is there any relationship to age and dose? And that is what the authors talk about over here, which is very similar to the initial calls that were made to CDCs and FDAs to say, please change the dosage for children. So here the researchers say, in contrast, 1/3 of the adolescents displayed antibody-bound S1 antigenemia. Emia means something in the blood. Antigenemia means antigen in the blood. After the second vaccination, regardless of the development of myocarditis. Even if somebody doesn't develop myocarditis, they have S1 with antibody bound to it in the blood. A finding not seen in a smaller sample of adults. So they say that we don't see this in adults. So why is it that children are showing spikes in the blood while adults are not? And then they talk about two primary possible answers. One is adults have a larger surface area, adults have a larger volume of blood, and so maybe smaller amount of S1 or spike protein produced becomes diluted and goes below the measuring threshold. or the dose for children is so much more that it triggers more spike production, so much more that children's immune system cannot handle it very well, and it starts spilling out in the blood. So here, this suggests that either the immune system of adults responds more quickly to the vaccine induced production of spike, or because of difference in body mass, the levels of S1 fall below the limit of detection. Alternatively, increased levels of free spike compared with free S1 may be attributable to a difference in renal clearance, kidneys. S1 would be expected to clear faster because it has smaller uh, size and weight, approximately half that of the full spike. And then they say because both adults and the adolescents included in our cohort received full dosing, adult dosing of the mRNA vaccine, this finding suggests an age-related capacity for handling vaccine-introduced antigens. Why do I keep talking about this part? Because I remember there were many messages to CDC and FDA to say, make sure that you look at the children's dosage and look at the body weights and the mass and then decide if the dose need to be lesser. And they never cared. At least to an observer, they didn't seem to care. Maybe they did a lot of internal meetings and spent another $1 billion on it, but we don't know that they actually did anything other than the same dose going everywhere. So because of that, I keep bringing this point up. So this is a discussion. Once again, quick references. This is drbeen.com, somewhere over here, if I can bring my mouse here. This is drbeen.com, link in the description to get access. This is the study in American Heart Association journal. This is the study as a free resource as well in NIH. This is the editorial, and then this is about the pericytes. So this is the discussion. Now, does it mean that everyone who has vaccine caused issues, they all have just the full spike protein issues? I don't think so. There are many phenotypes. There could be anti-idiotypical antibodies at play. There could be spike and these at play. There could be clotting at play. There could be mitochondrial dysfunctions at play. There are many reasons. Because of that, there are people who respond differently to various therapies and interventions. I just feel that sense of urgency for CDC and FDA to get ahead of these things and try to figure these out, and they should have been doing it a lot earlier. They have not, and that just is shameful. So with this, thank you very much. My usual message: like, subscribe, and share. There are links in the description if you would like to support this work. I would not mention what those links are. You can see them, but if you would like to support it, thank you very much for that. And Margaret, thank you very much for sending in a support donation today. Thank you. And I would see you tomorrow. I'm out for an interview. Then I'm going to fly out to FLCCC conference. I'll be back on 2nd May. I'll see if I can join from FLCCC conference. If not, then I'll see you on 2nd or after. Thank you, and see you next time. Bye.